Hello, this is part one of the high-risk newborn, and I'm recording this for my students who in class had the luxury of experiencing some construction noise in the background, so we've come up with an alternative way to give you your lecture content. But we're talking about the high-risk newborn, and this is part one. There are several parts to this, so you want to, after each part, click to the next one. So when we're talking about the high-risk baby, we're talking about a baby who may have gestational age issues. Maybe they were born preterm or born post-dates, or a baby that was born small for gestational age, or a low birth weight baby. These babies have a higher risk of infant mortality and morbidity. You can also have babies that are born with problems adjusting to external uterine life, babies that had some type of problem that developed during the antepartum period of time or during birth. You can have babies that may have some other type of issue, such as difficulty holding their blood sugar, or babies who have thermoregulation issues along with other problems. There are lots of factors that can bring us to this table, a lot of different conditions, and we've talked about most of these in class already. So I'm not going to re-lecture to these different disorders, but all of these factors can lead us to the delivery of a high-risk baby. When you look at the baby and you ask yourself, who is the high-risk infant? And I just kind of started to define that for you. It's babies who have congenital anomalies, babies who are born preterm or post-dates, babies who may be born small for gestational age or large for gestational age. Irrespective as to what has brought us to this table, and you're going to hear me use that term frequently today, there are some general concerns that all these babies will have. So difficulty holding their own blood sugar, difficulty holding or regulating their own body temperature. They may have developed respiratory distress syndrome or respiratory complications and problems with jaundice. And there's some other factors too that we're going to get into. When you look at this baby and you look at the needs of the baby and the needs of mom and the family, they may also, in addition to the physical nursing care that you're going to give, also need psychosocial support. There are lots of factors that can contribute to the baby's ability to survive or not, and this graph is showing you those different factors. The ethnicity and culture of the family, or religious beliefs of the family, the education and skill and background of the parents, their socioeconomic wealth. When you look at maternal factors, mom's nutrition, her occupation, her age, how many babies she has, and how far apart or close together they're spaced, the structure of their household. When you look at the healthcare system that's providing care to this baby, also can be a determining factor, such as, is it in close proximity to the facility where mom and dad live or where the parents live? Do they have regular access to this facility? Is the facility equipped and able to provide the needs that this high-risk family has? Do they have the resources, and do they have a competent staff? When you look at the baby itself, the sex of the baby, now you may not believe this, but sometimes little girls do better in high-risk situations than your male babies. Now, I'm not the person that can give you the answers as to why that is sometimes the case, but it is. The sex of the baby can be a factor. The gestational age of the baby at birth, the weight of the baby, the birth order of the baby, where the baby was delivered, how the baby was delivered, was the assistance and the competence of the assistance at the time of delivery, and were there any complications that developed. After delivery, the postnatal care for this baby, the baby's nutrition, is it being met, the hygiene in which the baby's the hygiene of the environment in which the baby is being kept, and is the baby able to get regular care? There are lots of interventions that we can put into place that also can affect this baby's ability to survive. But my point is, what I'm trying to get at is there are a lot of factors that can lead to survival or sadly a baby not surviving. When you first enter into a neonatal intensive care environment, what you might notice compared to a regular nursery or a regular hospital room is the room will be set up slightly differently. The lights will be dimmer. It will be a quieter environment. They may have a blanket over the baby's isolette. You'll notice that it's not a lot of loud, clangy noises, but it's a very low stimuli environment. And the reason we do that is babies that are high risk, babies that are preterm, their body systems sometimes are overwhelmed with just trying to meet their own metabolic needs, and they don't have enough reserve left over to handle a lot of extra stimuli. And so we try to keep as much as possible a low stimuli environment. That even being said, the devices that this baby is hooked up to can cause noise. They're all hooked up to alarms. So like the ventilator, the endotrache tube, which is hooked to a ventilator, your pulse oximeter, the IV lines, the temperature monitors, etc. All of these devices make noise, and the noise will bring stimuli to your baby. When you look at the care of the high-risk newborn baby, the care is it is directed at a baby who is susceptible to illness, a baby who's susceptible to death related to being born early, or problems with gestation, or physical disorders or complications that developed at birth. Now, the babies that we are talking about today are more than likely going to be at a level 3 or level 4 facility. I am not saying that a level 1 or level 2 facility is not a good hospital. That's not where I'm going. What I'm saying is that the needs of the baby, the interventions that we need to have in place because of the baby's needs, will not be able to be met at a level 1 or level 2 facility. They're more likely going to be met at a level 3 or level 4 facility. Now, if a baby is born at a level 1 or level 2 facility and it's found that this baby needs, has a higher level of care that is needed, that baby will be transferred to a level 3 or level 4 facility. When you look at the role of the nurse that is involved in working with a high-risk newborn baby, we play a big role. We identify and care for the immediate needs of babies as soon as they're born, whether they're preterm or post dates, and we provide care to them until we can transfer them into a high-risk environment such as a NICU, or we may be providing direct care in a NICU environment. We provide a lot of direct hands-on care to that baby, but we also provide emotional care and support for the parents as well. So this baby that we're talking about is a baby that sometimes has problems that may have begun before birth. Sometimes we're aware of those problems, and other times we are not aware. You may have a baby who was delivered early or had some complications that developed following birth. This is just an example of what I'm about to lead into, and this is a baby who had problems during labor and delivery, and had some variable decels and some other problems. Well, it became apparent after delivery that this baby had several knots in the umbilical cord. Now, that in of itself is a risk for this baby, but the problem was identified before delivery. They just didn't know exactly what that problem was, except for cord compression, but it could have led to a more serious outcome for this baby. So babies can be born with problems, and when you look at the immediate stabilization of a baby, and you'll learn as you work more in an OB environment, they'll provide additional training, but we do sometimes need to provide neonatal resuscitation. Our interventions may be centered around these 4 areas, and that's airway, the baby's airway, making sure that they're breathing, that they have a patent airway, their circulatory needs, and if we need to give them any medications, and we also want to keep them warm. And we've talked about thermoregulation already, but now it would be thermoregulation at the time of resuscitation. The healthiest babies will deliver at term. I've said that to you as my class repeatedly. You're going to hear me say that again. Babies that are born early have a higher risk for developing certain complications, and babies that are born post-dates have risks for developing complications as well. I'm not saying that babies that are born term have no problems. I'm saying your risks are greater in those two camps, preterm and post-term. But this graph is just showing you the areas in pink are babies that problems that babies typically have that are born preterm, and post-dates babies are in green, and babies that are born term, the problems are typically that are presented on the screen are in blue. Let's talk about classifications. I started this infant classification with you when we talked about the normal newborn, and I explained to you in class that we would finish the classification piece when we got to the high risk infant. So now we're going to finish that piece. Babies are classified, they could be preterm babies, late preterm, post term, or term, right? There's also weight classifications as well. You had in clinical an assignment where you were able to determine if your baby was small for gestational age, appropriate for gestational age, or large for gestational age, and you now know what that means based on what you did the first week in clinical. A baby that's small for gestational age is below the 10th percentile. A baby that's appropriate for gestational age is between the 10th and 90th percentile, and a baby that's large for gestational age is above the 90th percentile. But here's the other piece that was not given to you at the beginning, because there was more knowledge you needed to add under your belt. Now you're ready for that, and that has to do with weight. So when you look at your low birth weight babies, and that's what LBW stands for, you're looking at a baby that's approximately between 1,500 and 2,500 grams at birth. A VLBW baby, which stands for very low birth weight baby, is a baby that's between 1,000 and 1,500 grams. Usually that baby is somewhere between 29 and 32 weeks of gestation. And then you can have an EVLBW baby, an extremely very low birth weight baby. It's a baby that's born between 500 and 1,000 grams, or approximately between 22 and 28 weeks in gestation. So that completes your weight classification. We already talked about babies, how we determine if a baby's born term, if they're preterm or post-dates, but we didn't go into great depth about babies who are post-dates. This is sometimes called post-mature. Babies that are born after 42 weeks by textbook definition of gestation, who have progressive placental insufficiency. What you're going to see clinically is most healthcare teams don't wait to the point of we have placental insufficiency to act. They may induce mom prior to that, but there may be problems with her being able to deliver, or sometimes parental choice may play a role here as well. But a baby who's post-dates with placental insufficiency may be classified as post-mature. And this is the graft. I showed you how to do this graft already. We already completed that component during the first 2 lecture periods that you had with me for this class. Again, just a reminder, there are several factors that can lead us here to a baby being born with these problems. You can have maternal factors and conditions, fetal factors and conditions, and placental factors and conditions. Pop question. Are SGA and IUGR the same thing? If you answered no, you would be correct. They are not the same thing. You can have a baby that's born that's small for gestational age and a baby who has intrauterine growth restriction. In this picture, I'm showing you a baby, the baby on the left, who has both IUGR and SGA. And the baby on the right is appropriate for gestational age. Both of these babies are exactly the same gestational age. Let's talk about small for gestational age babies. Now, in my discussion, there are some similar needs that babies who are IUGR and SGA, they may have some similar problems and similar needs, but they are 2 different factors. You can have a baby who's small for gestational age, who's born, just below the 10th percentile. Now, IUGR can lead to a baby being born SGA, but it's not necessarily the same thing. So when you look at SGA, you have a baby that's